After discussing the general and basic hemodynamics, rules and regulations and the theories and everything, and then after discussing the arterial hemodynamics, now we come to the venous hemodynamics. Before studying the venous hemodynamics, we need to know something about the veins. And as we see here, these are the starting of the venous cycle in our body, and we have the venules, small veins, medium veins, superior and inferior vena cava, and big veins, and the heart. And this one, in the heart, we mean the right atrium. Okay, and then this is the arterial system, and we discussed this before. Some anatomic facts about the veins in our body, and we have the venules. Venules are the smallest of the veins, and they are up to 1 millimeter in diameter. They allow leukocytes, which are the white blood cells, to migrate in and out from the circulation to the tissues and returning back to the circulation. Medium veins, they are starting from 1 millimeter up to 10 millimeters, and they have inside them, they are having valves inside. Valves are important in allowing the venous return to the heart, especially in combination with the skeletal muscles contractions. This is called the skeletal muscle pump. And then we have large veins, which are 10 millimeters or higher. And these are the, for example, the IVC or the superior vena cava. 10 millimeters means 1 centimeter or higher. Of course, we know that the IVC is around 2 centimeters, right? They have thin tunica media, so there is some tunica media muscle layer, but it's not that much. Okay, so it has moderate amount of smooth muscles. Also, we have the venous sinuses. Venous sinuses, these are particular or specific kind of veins in our body. These are venous structures with thin walls, large lumen, and importantly, we have no smooth muscles, no vasomotion. So the tunica media is very thin. So it is mainly made of tunica intima and tunica adventitia and almost no muscle layer. That's why they are capacious. They can extend and stretch. Examples of these are the calf muscles, the venous sinus in the calf muscles, mainly the soleal and also the gastrocnemius muscles. They have venous sinuses, also the dural venous sinuses, which are intracranial, especially in the midline, in the brain, and also in the coronary sinus of the heart. When you come to the function of the venous circulation, we need to know something about the veins. They are called capacitance vessels. Capacitance because they can accommodate, of course within a limit, much more volume flow compared to the corresponding arteries. And even though they have little or no rise of pressure. So how veins are called capacitance vessels? Capacitance because they can change the shape. Veins can shape their shape to accommodate more blood. And we have here this comparison, or this chart is telling us what will be the shape in response to the volume flow. So there is here volume flow 2 to 8 mLs per second, and this is here 8 to 9 mLs per second, 9 to 10, and then 10 to 11. As you see here, there is gradual rise of the venous volume flow per second. And as you see it also in the shape is changing from flattened dumbbell shape to the oval, to the rounded, and then rounded and stretched. This is the one, the rounded and stretched, this will be the one associated with the highest pressure. So as you see here, compared to the pressure changes, the flattened or the dumbbell-shaped veins, they have the least pressure, 2 to 3 millimeter mercury. And as you see here, between the rounded and stretch, there is sudden rise, almost double of the venous pressure. Both are rounded, but one with the rounded stretch. Why this? Because as you see here, the venous flow starts from 9 to 10. 1 ml per second increase, this will have tremendous effect on the pressure. Why? Because the shape here changed to the maximum change that it can allow volume flow. But suddenly there is a little increase in the venous volume flow. This will be associated with sudden doubling, almost doubling of the pressure. So if you say that veins are capacitance vessels, this is mostly applied to this part of the flow. So we have here these 3 degrees. Once it reaches to the rounded, now they are not more capacitance, they are capacitance and pressure. And this is what we call the venous hypertension, and one of the pathological changes that happen in the lower extremities if we reach to this high pressure. To discuss the pressure, we need to know something called the transmural pressure. What is this transmural pressure? If I say that this is a vein and we have blood inside, and there is the interstitial or the tissues around the vein, there are pressures inside and outside. The pressure inside, the intravascular or the intraluminal pressure. Outside, this is the interstitial pressure. So we have 2 pressures that are acting on each other, and in between we have the transmural pressure. So what is the transmural pressure? The pressure of the wall, the pressure that is exerted on the wall. This is the balance between these 2 pressures, right? So transmural pressure is the balance between the intravascular interluminal pressure and the interstitial pressure. Elevation of the venous transmural pressure is called venous hypertension, and this is the one I just mentioned earlier, that is associated with the coronary venous insufficiency, a pathologic change that happens in the lower extremities in some cases. So after discussing the effect of venous flow on the shape of the vein and the pressure changes that happen in the vein, and we need to know what types of flow that happen in the vein. Usually veins are phasic. The type of flow in the veins is a phasic flow. Phasic flow, this is under the effect of the respiratory cycle. And this is the commonest type of flow in the veins. But we might have also sometimes steady flow. This is if you ask the patient to stop breathing temporarily for a while. And then the phasic flow will change to the steady flow, which have no changes responding to the respiratory cycle. And then we have the pulsatile flow. Pulsatile flow is sometimes normal physiological in veins close to the heart. For example, the superior vena cava, the subclavian veins, the jugular veins, or the inferior vena cava and the hepatic veins. All these are physiologically normally have pulsatile flow beside being phasic flow. But sometimes you might have also pathological pulsatile flow that happens usually in association with cardiac problems or volume overload or sometimes overhydration. So there are a lot of pathological conditions, some valvular problems in the heart. All these are pathologic changes that might be associated with pulsatile flow. So as we know that veins are carrying blood back to the heart, and in some cases, sometimes, or most of the times, is against the gravity. So there must be some force that is pushing the blood back to the heart. And there are many of these forces, and we'll discuss here some of them. The first one is the venous pressure gradient. What is the venous pressure gradient? The peripheral veins that are the small veins or the venules, they have higher pressure, like 12 to 18 millimeter higher pressure compared to the central venous pressure, which is in the right atrium. So there is now a pressure gradient between the peripheral veins and the central venous pressure, which is 5 millimeter mercury. And this pressure gradient is one of the factors that is pushing the blood back to the heart. The blood is moving from the higher pressure in the peripheral circulation to the lower pressure inside the right atrium of the heart. So the second factor that is affecting the venous return to the heart is the skeletal muscle pump. And the commonest example is the calf muscle pump. I'll discuss this later in detail. And this muscle is squeezing over the veins or the venous sinuses, and the blood flow is going back to the heart and is protected by the valves, the venous valves. So this is another factor. The third factor is the respiratory cycle. And respiratory cycle, we know that respiration is composed of inhaling and exhaling, or inspiration and expiration. This respiratory cycle is associated with intrathoracic pressure changes, and these are also acting on the venous return, making the blood flow what we call the phasic flow. Phasic flow is in response to the respiratory cycle. And the fourth factor, which is the gravity, but the gravity is not always with the venous return. Sometimes it's against, but again, it's one of the factors that is playing on the venous return to the heart. We start by the skeletal muscles and the venous flow. The commonest example is the calf muscle pump. This is here a picture for the calf muscle. Tibia and fibula, these are the calf muscle. We have the soleus muscle, this one, and the gastrocnemius muscle, this one. Both are connected together in one tendon called the tendon Achilles. So inside specifically the soleus muscle, there are venous sinuses, and we mentioned areas venous sinuses. They have no muscle layer, so they're made of intima and tunica intima and tunica adventitia, but no media. So they are capable of stretch and expansion. So if you are standing up for a while, what happened? These venous sinuses will fill with blood. But then when you move, what happened? The muscle will contract, and these muscles contract over the sinuses, pushing the blood up back to the circulation. In the presence of competent valves, this will keep the blood flow in one direction from distal to proximal. So this is the calf muscle calf muscle pump, and is associated with an association with the venous valves. This will end up by continuous flow, or helping the blood flow back to the heart. So this is here a way or illustration to show us what happened in the calf muscle pump. And as we see here, this illustration, the muscles here around the vein in the middle, the vein here, and the vein, as you see, it has valves inside. So what happened during contraction, muscle contraction? It will squeeze over the veins in the middle here, so the blood is pushed up inside the veins and the soleal venous sinuses. The veins here in the calf muscle, they are the posterior vein and the peroneal veins. We know this. So these are the veins that are compressed by the blood, by the muscles, and the blood is pushed up. This will open the proximal valves. So the proximal valves are open and allowing the blood to go up. So this happened during muscle contraction. Okay. During muscle relaxation, what happened? The skeletal muscles, the gastrocnemius and soleus muscles are relaxing now. What happened? Okay. The blood is, in a way, it starts to return back from the blood pushed up. It starts to return back. As it returns back, it closes the proximal valves. But when the muscle relaxes here, it allows some room inside the vein, and this increased capacity or increased volume in the vein, it allows to the distal blood from the distal veins, it will collect back inside this area. So this area now starts to fill with blood. So during relaxation, the soleal sinuses, the posterior tibial vein, and the peroneal veins, this is the filling phase of these veins. Okay, so it starts the filling phase here, and then when the contraction, it goes in the emptying phase. Another factor that is affecting the venous return, this is the breathing or the respiratory cycle. Okay, and we know that the main component in the respiratory cycle is the diaphragm. The diaphragm is a muscle, skeletal muscle, that is separating the thoracic from the abdominal cavities. We have thoracic cavity here, abdominal cavity here, and the diaphragm in between. Okay. During respiration, what happened? we have the inhalation and exhalation. What happened here in exhaling or inhaling? The diaphragm is the main component to move. So the diaphragm might go upwards toward the thoracic or downwards towards the abdominal cavities. This will change the pressures in the thoracic pressure and abdominal pressure. This movement of diaphragm is the main factor responsible for what we call the phasic flow. Phasic flow, it happens in the venous circulation because of this movement of the diaphragmatic muscle. So what happened in inspiration? Inspiration or inhaling, okay? What happened? The diaphragm goes down. So this is the original position of the diaphragm. Now diaphragm goes down. Will create negative pressure in the thoracic cavity and will create positive pressure in the abdominal cavity. What happened next? Because of this negative pressure here, okay, the thoracic pressure is lower, negative pressure. It allows more blood from the head and neck and from the upper extremities to get into the thoracic cavity. So there is the upper extremity veins. It's higher, neck venous flow is higher. So now we have here, because of the negative thoracic pressure, I have upper extremity venous flow and the neck venous flow are higher. Now, what happened in the abdominal cavity? Abdominal cavity, we have increased pressure. Why? Because the diaphragm, again, as we mentioned, is going down, pressing over the abdominal cavity. It creates a positive pressure. So the pressure here inside the abdominal cavity is higher. What happened? The lower extremities, these are the lower extremities here. These pale arrows here. The lower extremity venous flow gets lower. So as we see here, the diaphragm is going lower. The lower extremity venous flow is lower. Notice this, guys. Notice this. When the diaphragm goes down, the venous flow in the lower extremity goes down. And as we see here, also need to notice something here. Upper extremity flow and the lower extremity flow, they are the opposite. So if this is lower, this will be higher. All right? So we keep an eye on these movements: the diaphragm, the lower extremity, and the upper extremity. And also notice the pressures inside the abdominal cavity and thoracic cavity in comparison by the movement of the diaphragm. Now, what happened in expiration? Expiration, what happened? The diaphragm goes higher. So it goes from here. This is the original position. Now the diaphragm moves up. What happened here when the diaphragm moves up? The thoracic pressure gets higher. So what happened to the flow in the upper extremities and from head and neck? Both are lowered. Why? Because the pressure here gets higher. So the thoracic pressure gets higher, the upper extremity flow gets lower, and the neck venous flow is lowered. Okay. On the other side, we have here abdominal cavity. Abdominal cavity the pressure gets lower. What happened to the venous from the lower extremity is gets higher. So as we see here, compare the movement of the diaphragm. The diaphragm goes higher, the lower extremity flow goes higher, and the opposite will happen to the upper extremity flow, which will be lower. So as we see here, diaphragm higher, lower extremity higher, upper extremity is the opposite. All right. So some notes about the breathing and venous flow. Lower extremities, the flow rate is following the diaphragmatic direction. I mentioned this here. Diaphragm high, lower extremity flow will get higher. Diaphragm goes lower, the lower extremity flow gets lower. Upper extremities are always upper extremities and venous flow in the neck, from the neck, okay, and the IVC. All of these are the opposite. They go in the opposite direction of the venous flow in the lower extremities. So if the movement of the diaphragm is followed by the movement of the lower extremities, and the opposite will happen in the upper extremity, neck veins, and IVC. All of these are called the venous return, and they are the opposite of the diaphragmatic direction. In inspiration, increase the venous return to the heart from the upper body. So with inspiration, the venous return, because inspiration will have negative pressure in the thorax, and this will increase the venous return to the heart. Another factor is what we call the hydrostatic pressure. To define hydrostatic pressure, guys, this is the weight of a blood column that is pressing against the vessel wall. It's from the heart level to the point of measurement. So if imagine that I want to measure the hydrostatic pressure here. Start from the heart, make a column of blood to the level of the knee. If I want to get the pressure, and for example at the top of the head, I go from the heart, make a venous a column of blood to that level of the top of the head. So again, what is the hydrostatic pressure? It's the weight of a blood column pressing, well, the blood column is pressing over the wall of the vessel. So the weight of a blood column from the heart level to the point of measurement. Okay, the measured pressure or the total pressure is what? The hydrostatic pressure plus the core pressure. Core pressure, that is the pressure in the heart. So the measure or the total pressure is what? It's the core pressure plus the hydrostatic pressure. This is the hydrostatic pressure. This the blood columns here. But there's a pressure inside the heart too, and this is called the core pressure. So we have core pressure here and hydrostatic pressure here. These two, the core pressure and the hydrostatic pressure, will end up by what we call the total pressure. So the total pressure or the measured pressure is the addition of the hydrostatic plus the core pressure. So this is here the circulatory pressure or the core pressure. Okay, the core pressure in the venous side, we consider the right atrium of the heart. The right atrium is the circulatory pressure or the core pressure in the venous side. And usually this is 5 to 10 millimeter mercury. And we mentioned earlier that the right arterial pressure usually around 5 millimeter, but when the atrium might contract, it might rise up to 10 millimeter mercury. So 5 to 10 millimeter mercury is just the core pressure in the atrium. Okay, now we come to the core pressure in the arterial side. For the arterial side, we have the pressure in the left ventricle. So the left ventricle here is representing the circulatory pressure or the core pressure for the arterial side. And usually it goes by 120 up to 100 or 100 up to 120 millimeter mercury. So again, circulatory pressure in the venous side, 100 to 120, and the circulatory pressure in the venous side is 5 to 10 millimeter mercury. Now we have something called the zero pressure. Zero pressure means what? Zero pressure hydrostatic. Zero pressure hydrostatic, not the core pressure. We talk about the hydrostatic pressure now. So hydrostatic pressure zero. When this will happen? Will happen at the level of the heart, because this is now, there's no blood column. This is the level of the heart here, we have no blood column. So at the level of the heart, anything about the level of the heart is zero pressure. For example, the brachial area here, or the biceps muscle, the brachial vessels here. Again, this is the same zero pressure. What else? If you have a patient supine, so all the points of the body, all the points of the body, ankle, knees, waist, upper extremities, head, hands, every part of the body is having the same pressure, which is the same level of the heart. So all the body parts are having hydrostatic pressure zero. So when we have zero pressure, again zero hydrostatic at the level of the heart, at the biceps or the biceps muscle or the brachial vessels, and when your patient is supine. This is a tricky question, guys. Sometimes it happens in the exams. They ask you, what is the supine, what is the hydrostatic pressure, for example, at the ankle area here, but the patient is supine. So it's not 100 millimeter mercury. No, it is zero, because in supine, all the points are zero. If it's standing, there's changes, but if the supine, all the points will be zero. So don't fall in this trap. So when you the pressure in the supine, every single point in our body is having hydrostatic pressure zero. In supine, every point having hydrostatic pressure zero. This is in supine. What happened in standing position? In standing position, what is the hydrostatic pressure again? It's the weight of a blood column from the point of the heart to the point of measurement. So if you go here, for example, at the fingertips when they have elevated hand, what with the weight of a blood column is 50 millimeter mercury, right? And what will happen here if we have from the top of the head is 30 millimeter mercury. Again, from the top of the head to the level of the heart, 30 millimeter mercury. Okay, at the level of the heart itself is 0, mentioned this before. Heart and brachial area. And now go here, excuse me, go here at the waist level, at the level of the waist is 50 millimeter mercury. Again, weight of blood column from the heart to the waist area. What will be the weight of blood column from the heart to the knee area? 75 millimeter mercury, and down to the ankle usually is 100 millimeter mercury. These numbers are usually measured in the average height persons, not too tall, not too short. So average height persons are having these measurements in the hydrostatic pressure. When it comes to the when it comes to the pressure, excuse me, when it comes to the pressure above the heart, okay, somebody will say it should be negative, right? It should be negative if we have this in clay type pipes or in metal pipes, but not in veins. Why? Because in veins, the veins are collapsible. Collapsible means they are coaptable. They cannot stand to have intravascular or interluminal negative pressure. Once there is a pressure below 0, the walls of the veins are already collapsed together because of the 0 pressure. They will not allow for a negative pressure to happen. Why? Because again, veins are collapsible or coaptable, and this cannot stand, as we see here, cannot stand having a negative intraluminal pressure value. So the pressure of the veins above the heart are usually 0 measurements. We don't go by negative. So now in these 2 coming slides, we will talk about the effect of hydrostatic pressure on the venous and the arterial pressures in our body. Okay, and we know that the total pressure or the measured pressure is the summation of circulatory pressure plus hydrostatic pressure. Hydrostatic pressure, this is the one that we measure by the column of blood. Circulatory pressure or the core pressure, this is related to the heart, either the right atrium when it comes to the venous, like we talked in this slide, or the left ventricle when we talked about the arterial, as in the next slide. So again, circulatory pressure, the pressure in the heart, hydrostatic pressure, the weight of the blood column, and the total pressure with the addition of these two. So the measured pressure or the total pressure. We have these applied to different locations in the body, as we mentioned earlier: upstretched hand, the head, the heart, and the biceps area, and also the supine position, the level of the waist, the level of the knee, and the level of the ankle areas. So circulatory pressure is constant all the time. This is 10 millimeter mercury. Why? Because this is the pressure inside the atrium. It does not change with your body changing positions. And then we have the hydrostatic pressure. This is the one that changes with the points in the body. So we have for example, the upstretched hand is negative 50, top of the head is almost negative 30, the heart or the brachial area or the supine is 0, hydrostatic 0. We have 50 at the waist, 75 at the knee, and 100 millimeter mercury at the level of the ankle. So we come to the total pressures here. Total pressures, as again, total pressure or the measured pressure is the summation of these two. So if I'm having, for example, if I talk about the upstretched hand, okay, what would be the total pressure? Total pressure 10 minus 50 should be negative 40, but it will not go negative 40. Why? Again, because of the veins are having collapsible walls. So the walls are collapsed and they will not allow creation of negative pressure inside. It might have negative pressure if you have a pipe like metal pipe, for example. Negative, there is a room inside. So this will allow negative pressure to be created inside this lumen. But since veins are collapsible, there is no room to allow negative pressure. So the pressure will be what? 0 in the upstretched hand. And the top of the head, the same story. I will have here negative 30 plus 10. I should have negative 20, but it will not happen. Again, because the veins are collapsible. At the level of the heart and the brachial area and a supine patient, I have 10 core pressure or circulatory pressure. Hydrostatic, how much? 0. Okay, we mentioned this 0. So total pressure will be 10. So if I'm telling you what will be the total pressure in a supine patient at the level of the ankle, is 10. At the level of the waist, 10. At the level of the head, 10. Any area of the body is 10. Why? Because I have 10 millimeter. This is the addition of 0 plus 10. It's 10 millimeter mercury. Right? When it comes to the below the heart level, I have 3 locations here: the waist, the knee, and the ankle. Again, the waist 50, knee 75, ankle area is 100. I have here the total pressure will be 60, 10 plus 50 in the waist. At the knee level, we have 10 plus 75, we get 85. At the ankle area, we have 10 plus 100 millimeter mercury hydrostatic, okay, total of 110. So these venous pressures here, as you see, they are getting higher because of the standing position and the venous flow. Okay, when it comes, somebody will ask me, is it clinically applicable here? So I don't think that is going to be that high. Why? Because the venous valves are dividing the column of blood into segments. So between a valve and the next valve, there's a segment of blood, and this segment of blood doesn't carry the weight to the next segment. So I have the column of blood is divided into segments. So the total pressure here will not be exactly as the hydrostatic plus the circulatory pressure. Okay, if it happened that we have incompetent valves, like what happened, for example, in varicose veins, or a condition called chronic venous insufficiency. We have deep veins or superficial veins that lose the competency of the valves. These pressures will be exerted there. So you'll have this, what we call venous hypertension. Venous hypertension, why? Because the valves are now destroyed, not competent, and I will have now the continuous column of blood from the heart down to the area that we measure. And this will show me what we call the venous hypertension. As you see here, the commonest thing, it happened here, the highest pressure will happen at the ankle area. And as we mentioned, probably you have studied this in the venous pathology, okay, that there is something called here that the ulcers, venous ulcers, and venous hypertension, and venous insufficiency, and you get here venous ulcer, the changes of the skin, all of this happen mainly at the ankle of the area. Why? Because it's the highest pressure happened there. Now we go for the hydrostatic pressure and its effect on the arterial circulation or arterial pressures. All right. So as we see here, it's the same pattern. We have the circulatory pressure, but we take here the highest of the circulatory pressure, 120. Okay, this is the pressure in the area, left ventricle. And we have here the hydrostatic pressures, which are, again, they are here as the same as hydrostatic pressure in the veins. This is the same hydrostatic pressure. It doesn't change with the arteries or veins. And then we have the total pressure. Again, total pressure, measured pressure. This is the pressure, the summation of the circulatory pressure to the hydrostatic pressure. Okay, now come here. Outstretched hand. We have 120 minus 50, again 70 millimeter mercury. So if you stretch your hand all the way up toward the ceiling, and you measure the arterial pressure at the fingers, it will be 70 millimeter mercury, right? So if you come to the head, if you measure the blood pressure at the level of the head, is 90 millimeter mercury. Why? 120 minus 30, I will get 90 millimeter mercury. At the level of the heart and the brachial area and a supine position, okay, the blood pressure will be 120 millimeter mercury. Okay, this is the reason why if you measure the blood pressure of a patient, this is a clinical application. If you measure the blood pressure of a patient, okay, you need to measure it without the effect of the hydrostatic. I need to see what is the actual pressure of this patient. I'm not going to measure or will not be under the effect of the hydrostatic pressure over the arterial pressure. I need to see the real arterial pressure. How can I measure it? At the level of the heart, where? At the brachial area. So that's why you wrap the cuff of the sphygmomanometer, which is the device you use to measure the blood pressure. We wrap it around the brachial area. Why? Because this has zero hydrostatic. I'm measuring the true arterial pressure without the effect of the hydrostatic pressure on my measurement. Okay, somebody will say, but sometimes there are new devices now that you can wrap it around the wrist area. Okay, again, you need to ask the patient to read the hand to keep the level of the device at the level of the heart. So they put the hand touching the shoulder, the opposite shoulder. So the wrist area will be again at the level of the heart. Right. Again, if we go down, so this is here, the waist area will be 170, the knee area will be 195. Why? Because 120 plus 75. Again, at the ankle area, we have the 220, which is 120 plus 100 hydrostatic pressure, circulatory pressure plus hydrostatic pressure. The total pressure 220. So if you get the patient, for example, assuming that we have a standing up patient and you need to measure the arterial pressure at the ankle area, you will find that is in the range of 220. Why? Because the true pressure, the arterial pressure, which is 120, the circulatory, add to that the 100 of the hydrostatic pressure. Thank you, everybody, and I hope that was beneficial, and see you later in some other lectures for physics.